Hi guys, this is Charles. I'm one of the surgeons at the Animal Emergency Centre in Melbourne, Australia. And we are operating on the patient that I reviewed the radiographs on before. So this dog has a medially luxating patella. You can see that it's luxated now, reduced, luxated, and reduced. And so the key is going to be first to check the cruciate ligament, make sure that that is intact, and then decide what kind of repair we're going to do. The tibial crest is displaced a little bit medially, so I think that that's probably going to have to be part of our repair. When I make my incision, I use the distance between the patella and the tibial crest as the medial third of my incision. Just push your stool. You probably don't. Do you need a stool? Okay. So that's the middle third, so I'm going to go a third up, the middle, and then a third down. So this is called a lateral parapatellar incision. Once I've made my skin incision, I use my electric cautery. If you haven't already done so, please subscribe to our channel. I'm actually amazed at how many people that watch these that are not subscribed, and you really should, because that means that you'll get notified when we are live streaming again. So if you're not subscribed, please subscribe. Share the love.
I'm subscribed. Me too.
Emma is subscribed. Ines is subscribed. It's fun. Everybody's doing
I
it.
saw the searches from last week pop up on my recommendations last night. I was like, wait, hang on.
Can I get Gelpies, please? All right, so we'll get our Mets and bombs. I might get you to just hold up on that, please, for me.
Yeah.
All right. So just dissecting through the sub-Q. And then I'm going to go immediately lateral to that patellar tendon. Yes. All right, so I'm going to do a little punch through the fascia lata, and then I'll extend my incision using my Metson bombs. Okay, and it's really important on this one particularly that we do an exploration of the joint, because I was concerned that the cruciate ligament might have been affected as well based on the presence of effusion, because we usually don't see that much effusion with just patellar luxation. It's very inflamed, this joint, with the amount of bleeding that we're getting. It's more than usual.
During the electrosurgery, you can use the suction to suck up. Yeah.
Is the suction plugged in, by the way? And turned on?
I'll learn the dumb thing of suctioning when there's no suction.
All right, so one other thing that I've noticed is maybe a little bit of DJD here, not too much. It's actually fine. All right, so as I'm cauterizing, yeah. Okay, all right, so key thing here is going to be to look at that cruciate ligament.
That's a fat pad.
That's all fat pad, yep. All right, so looking down here, I don't know if you guys can see it, but the cruciate ligament is intact. Can I please get some Sen retractors and Homans? So I don't think you guys will be able to see the cruciate ligament, but I'm just going to get some Sens and you'll be able to see it better. Go ahead and extend while I'm waiting my incision down the lateral tibial crest here because I know I'm going to have to do that for my tibial crest transposition. Okay. All right, sends, please. And then a home in. We'll go ahead and get everything open, please. Except we don't need another pair of Kelpies. All right, so maybe you guys will be able to see that cruciate ligament. I'll try to redirect my light a little bit. Yeah, I don't think you're going to be able to see it, but the cruciate ligament is intact completely. All right, so get some lavage, please. Do a little flush of the joint. Hold on to that, please, just like that. Go ahead and suction. B? Nah. Just a couple of homins, and then the saw, the pin pack, pin cutter. All right, so we'll go ahead and take this out here. Now I'm not going to close the joint yet because I may have to still do a trochleoplasty. I don't think I will, but I might. I reserve the right to do a trochleoplasty. Just going to move the camera around a little bit, just to give you a little better view. I'm just going to put a homen in here and leave that like that. Yep. And then we'll put another homen. Did we get two of them? Did we get two homens? Thank you. I'm going to need some 19 gauge cerclage wire, please, when you get a chance. All right, so one homen is going to be to expose, and the other is going to be to protect the tibial crest. Okay, so that's a really nice exposure of that. Thank you. Need a saw blade, please. That little guy there. 19, please. All right, I'll give that to you. Thank you. I'm just mounting my blade now. My glove is stuck. Okay. So now what I want to do is, remember we've got a growth plate that's coming right along here. All right, and so I want to take a nice big chunk of tibial crest. And I'm going to do something that I don't normally do in the past, but somebody suggested it as an idea, and that is to drill a little hole in the tibia at the distal end of our osteotomy, and that is to prevent that little fracture of the osteotomy.
Oh, so it would like naturally stop itself.
Yeah. All right.
Clever.
So I'll just come in here. So I'm putting in a little pinhole. Okay. All right, and then just make sure that I can see where my pinhole was. So there's our pinhole there. So that's where I'm going to direct my cut. Okay. Just make sure I got all the way down there to the hole. I did. All right. Can I please have a bung clamp, pointed reduction forceps, a large one? Thank you. So we've released that piece of bone there. Now the other thing that I'd like to do is make a little landing pad where, make a landing pad where the bone is going to go when I move it. So we'll just move that over to here. Okay. All right, so now we'll take that Homan out, and that one. All right, and then I'm going to move this across. Like that. Okay, so that's where it's going to go. And then I'm just going to make sure that my patella wants to stay in. So it wants to stay in. It can pop out, so I might even move it over a little bit further. Like that. Okay, so you can see that we have moved it across quite a bit. So that really wants to stay in. All right, so now lift that up like that for me. And I need to put my pins in quite high. See how big my bone is. Let's see if Those are good. So I want to use pins that are quite large because they're going to be supporting this whole thing. And I don't want them to be so large that they're going to fracture. And I'm going quite high on the tibial crest. Just hitting the caudal cortex. Okay, so that's just gone through the caudal cortex. Just make sure that that looks about right. Yep. Okay, so I'm happy with that. Now we'll take off point of reduction forceps and make sure that it wants to stay there. It does. Okay, and then make sure that those feel solid. You can still luxate, but when it straightens, it wants to stay in. All right, and then I'll do an imbrication as well. All right, so let's get some homins here. Okay, so hold on to that, and then I'm going to make a little hole from lateral to medial, and then I'm going to put in a piece of cerclage wire as a tension band to try to keep it in place. Can I get the wire twisters, please? All right, so just drill a hole here. Go smaller, I reckon. I'll pass my wire from lateral to medial. Just like that. And then twist it over the top like that. I'll just put my little twist there medially. We have to make sure that we pull as we twist to make those twists nice and even. Okay. And then I need to bend these pins over, and the way that I do it is I actually want to bend them away and then twist them around like that. Bend away and then twist it around, and that makes sure that the bend is as close to the wire as it possibly can be. All right, and then we just cut here and here, and Bob's your uncle. All right, so that's good. We'll take that out, and then I'll just get a Gelpy back in here. Can I please get some OPDS? All right, so I'm going to do an imbrication here. It's called a vest over pants imbrication. The way that works is that I'm going to take a bite through and through here. Actually, I have to go through and through like that. And then I'm going to just take a . just a bite on the lateral surface here. And we'll see that when I pull this tight, it's going to pull it one over the other. So that's why it's called a vest over pants. So you'll see that when I pull that tight, it pulls one. So it pulls the cranial segment over the caudal segment. Yep, maybe a bit long, so 3 mil. Yep. I don't think the announcement went out because nobody's commented. It'll go after the fact. All right, so then through and through, and then a nice big lateral bite out here.
So through and through and then over.
Yeah. Oh, better off using those. See how that makes it overlap? And that gives you a little bit more strength. Yep. Beautiful, thank you.
You do the fasciolata.
That's fasciolata, yeah.
You do like more of the, is that where you do the imbrication? I don't do it more.
Cranial?
I guess.
No. No, the fasciolata is the most important layer. That's the one with the most holding strength. I think we'll find that when I'm finished with this layer, there's no way we'll be able to luxate that patella.
So when you do the transposition, do you, like you don't want to overdo it if you're going to imbricate later? Do you leave a little bit?
You don't want to overdo it because you don't want to create a laterally luxating patella. So it is a little bit of a kind of an art thing, figuring out how much to transpose it. Can I please get some, can you grab me some 2O PDS, please? And then we need to get some soft tissue to cover those pins. So I'll try to bring that across, like that, just so that you don't get, you're less likely to get a seroma. Thank you. Oopsie. Michaela, can you ask them please to pre-med my next one, if anybody's available? What's that?
I said it was very smooth. Really, really pretty.
It's like ASMR watching.
Yeah, really.
Watching the procedure.
I'm very, very relaxed.
And then they're like, oh, do you want to? And then you're like, oh wait,
Yeah.
now those students there.
Back in the real world. Just want to make sure we don't grab the underside of the dermis or it bunches it together. I'll show you in just a second what I mean. So you just want to grab the really loose tissue on this layer. So if you grab that, see how it bunches it?
Oh, okay.
You just want to grab the loose tissue like that.
It really wants to.
Yeah.
Do you know how to trail suture?
I'm not sure. I'll show you.
And just grab it and then let it go when I'm ready to pull it through.
Okay.
So go ahead and grab that. Grab that. Okay.
And the goal is to maintain the tension.
Yeah, it helps prevent this continuous from coming undone.
Yeah.
And then also, I find it's like a really common thing with Stifles actually, especially with the memory, it can
Yeah.
get caught on things, so it helps keep it out of the way.
For sure.
Okay.
Charles often does too.
Yeah.
Right?
Mm.
Malcolm does one.
Is it easier to do it too? Or
Just
is it
faster.
Yeah.
I'm impatient with myself.
I had a surgeon that I think he wasn't used to asking for help, and so then when I did trail with him,
Yeah.
he felt bad, and so then he would do like 4 throws.
And then it gets
Really, really
caught and sometimes the suture breaks. Now, Emma, you can do sub-Q or intradermal, whatever you want. When you do a loop like that, you always have to pull on both ends of the loop to make sure that it tightens. We'll just cut that one, and I'll try to draw that, yep, underneath. Maybe. Yep. It's not going to stay underneath. You'll have to fix that with your intradermal. All right, so just intradermal or skins, whatever you like. Do you prefer intradermal or? Okay, all right, so that's pretty much it. Let's just check our patella. That's not going anywhere. Good range of motion. I don't feel big pins sticking out the back. So I think we're in really good shape. So go ahead and wind up that live stream. If you haven't already done so, please subscribe to our channel. Make sure you turn on notifications so you get a ding on your phone the next time we live stream.